Nice to have everybody here, particularly the newcomers. Welcome. Our topic today is titled PF Therapy, the Latest and the Greatest. Our latest news about enhancements to therapy will be presented by the greatest pulmonologist and care specialist, Dr. Yolanda Mageto. She is the medical director of the Interstitial Lung Disease Center here at Baylor in Dallas. She's a clinician, an educator, and a researcher, in addition to being a pulmonologist. She's been involved in many IPF, ILD trials, clinical trials, and is actively involved in that now. And she does this in collaboration with other clinical researchers all around the country from major hospitals. When she's not at the clinic, Yolanda enjoys her family, travel, reading, cooking, and skydiving. I lied about the skydiving. Yeah, I thought it was just kind of something I ought to throw in there. Excuse me, Dr. Mageto, for that. In spite of the full schedule of clinical work, Dr. Mageto remains very active and involved with total care of her own patients. I know, I'm one of them. After her residency at UT Southwestern, she completed a fellowship in pulmonary and critical care medicine at the University of Washington in Seattle. And later she was in faculty positions at the University of Washington, UT Southwestern, and became a full professor at the University of Vermont. I don't know how that happened, but it did. So now with I'm in big trouble, I can see.
You get 2 PFTs next time.
But now for the latest news from the greatest pulmonologist that I know, please welcome Dr. Yolanda Mageto. Forgive me for that. I just couldn't resist.
Oh boy, you had fun with that, I can tell. Where did you get all that? You went digging. I'm impressed.
I'm a researcher too.
I see. Yeah, I love all those extracurricular activities that I have so much time to do. Most of my extra time is spent with my 3 kids, 21, 15, and 17. So, college coming up. Shelley asked me to do this about a month ago, and she sort of said, I just want you to talk about some of the ATS stuff and clinical trials, and then she asked me, what's your title? And I hadn't really given it much thought, so I said, oh, well, since you want me to talk about the newest stuff, we'll talk about pulmonary fibrosis, the latest and greatest. And then I started to do the talk. And I realized that's pretty broad. So I asked her, narrow it down for me and tell me what you really want me to talk about. So she talked about wanting to talk about clinical trials, sort of what to think about, how to look at them, how to approach them. And then I threw in some of the new research or some of the later, most recent papers that have come out in the last year in terms of clinical trials and progress in pulmonary fibrosis. So that's where we're going to start today and move through. So the disclaimer is, if anybody walked in thinking I'm about to give you the cure to IPF, put your pens away, because it's not coming today, but hopefully it will be coming down the road. So why clinical trials? And I'm glad that we have all these new people. I actually started thinking, maybe I should have done my other talk, my introductory talk to pulmonary fibrosis and IPF. But if you have any questions, feel free to ask. Everybody who knows me will tell you. I really don't care what the topic is. I'm happy to talk about it. So this is where we were in the 1990s. I'm dating myself. Latest and greatest, nothing, 0. 2019, those are just a few of the trials that are currently ongoing. There are at least 20 or 30 IPF trials that have been gone through in the last decade alone. So we're making progress. And I'd like to start off talking about what clinical trials are, why they're important, what the actual process is, informed consent, why people don't participate. I'm curious, how many people in this room are in a clinical trial right now? I have 1, 2, 3, 4. See? That's not that many. We can't get the cures to come out if we don't have people in the trial. So, and then I'll talk about the clinical year in review and a little bit about stem cell research. And then Shelley mentioned talking about non-medical trials and therapies. I will be out of time, so next time, and then I'm going to grab Amanda, who's sitting over there, who knows a lot about diet. She's going to come do the next one with me. See, I've already told her. She didn't know that I was going to say that. So you've been warned. So what's a clinical trial? It's a research study involving just the humans, and it compares a new treatment to the existing standard of care. So in IPF world, there was no existing standard of care. It was basically the Wild West, and everybody got treated with whatever everybody thought worked. Even now, we still argue about what the best approach to care is, but we're moving in the right direction where there's at least some unity in terms of how we should do this. So why do we do these? We need to improve current treatments. We have drugs on the market for IPF right now, but as you all know, they don't cure the disease. They simply slow the rate of progression. And I'm willing to bet my last dollar that everybody in this room would prefer a drug that reverses fibrosis, or I can guarantee you it would stop it dead in its track. We don't have that yet. It will reduce the risk of recurrence while in diseases like cancer, or find cures for diseases like diabetes, pulmonary fibrosis, and so on. Or maybe we can pick up diseases earlier so we can cure them earlier. So case in point, if you pick up a stage 1 lung cancer, your survival at 5 years is 95%. If you pick it up at stage 4, it's 5%. Help preventing disease, so the new HPV vaccines that came out a few years ago. And then improving survival and quality of life. That last one, I think, is a more recent approach to clinical trials, because people used to think about just treating you and giving you medicine, but let's be real. How many people think that quality of life is more important than feeling miserable on a drug? I mean, think about it. If I said to you, I could give you 2 years of a fabulous life, or I can give you 4 years of misery stuck in a bed. Most people would take the 2 years of a fabulous life. So more and more clinical trials are paying attention to not just survival, but quality of life survival. Slide doesn't move. There we go. So first step, we have to be aware of it. And a lot of people aren't aware of clinical trials, or they don't know how to access them, or they don't know how to find them or look for them. And that's one of the major barriers for recruitment into a clinical trial. So we need to do better at getting people in. Now, we know from studies that people who are aware of things, their attitudes tend to change towards those things. So we know that 32%, so about a third of patients, they'd be willing to participate if someone asked them. They don't participate because no one asked them to do so. 28% would consider it, but they have some reservations. And then we have focus groups that people just don't know what a clinical trial is all about, and everybody's scared of the placebo. I don't want to be on a drug and I don't want to be on nothing. I need to be on something. And not all clinical trials, by the way, are placebo. So if you have that fear, look for a trial that doesn't have a placebo in it. They exist. All right, so why are they important? New and better treatments. And we can have all the treatments in the world, but if they don't work, it doesn't make sense, right? So we need to know if they're efficacious and they're safe. Many of you remember the thalidomide in the 1960s, where it was approved with minimal studies based on the European results, and we ended up with a lot of birth defects as a result. So it's important to determine if the treatment itself is safe. So new treatments actually take a long time before coming available. People just, they ask, well, how come we don't have anything? And I understand that frustration because I feel it too, but it really does take 2 to 3 years to develop the trial, another 2 to 3 to actually do the trial. Then you're running all the information. So you're already 5 to 6 years down the road from the minute you started the clinical trial, not the stuff that comes before the trial. So it takes a long time. They also aim to enhance new or existing treatments or diagnostic strategies. So we investigate and compare. So we want to promote progress in the treatment. And when we look at pulmonary fibrosis, so I did this and I said, all right, so why is it important for PF? Every new treatment we have has gone through a clinical trial. The faster we enroll, the faster we get to the results. If the results are positive, the faster the drug gets approved. New therapies, we have to base them on understanding how pulmonary fibrosis develops and progresses. That's been one of the hardest things about this disease. Figuring out how the disease occurs, what causes it, and how it progresses. And as I will bet, every person in this room has a little bit of a different story in how the disease started with them. New models let us develop new drugs that work better. So if I look at the diabetes world, there's so many new types of insulin, I no longer am willing to even try and prescribe insulin for somebody because there's so many new types out there for so many different types of diabetes. When I trained, diabetes was diabetes. Either you had it or you didn't. Now you have different types of diabetes, different types of insulin. We are getting that way with pulmonary fibrosis, different types of pulmonary fibrosis. So even within the world of idiopathic pulmonary fibrosis, now we're having an autoimmune-based, something called IPAF, connective tissue-related pulmonary fibrosis, drug-related pulmonary fibrosis. They're all just a little bit different when you look at them. So they're not exactly the same, which means we might need to approach them differently in how we treat. And then there's that emphasis on quality of life that I mentioned in the public health issue. So, are you considering enrolling in the clinical trials? Let me ask this question. How many of you have had a physician ask you to be in a clinical trial? Wow. Okay. I need to go find my ILD colleagues and have a conversation. This is interesting. So there are lots of clinical trials around, and it's interesting that very few people in this room have even been asked. Why do people even bother? Now, I've had patients tell me a number of reasons. Many, they want to benefit from access to the treatment, because if you're in the trial, you get first access, first cut to it. But, caveat to that, you have to remember the new treatment may be worse or it may not work. So that's why we do the controlled trials. So if the treatment is likely to benefit you, you should seriously consider participating. It's an opportunity that you're going to get the drug before it's available on the market. Clinical trial participants often, I've heard this a lot over the years, is that, doc, I know it's not going to help me, but it may help my kids, it may help family, it may help other people down the road, and so they want to be in the clinical trial. So, guess what? You didn't get to sit still there and watch me talk for the last hour or so. Little participation here. The results of the clinical trials, then, always represent improvement of the standard available treatment. How many think that's true? How many think it's false? Okay, you all pass. Let's go home. All right, next. So it is true. So even if many trials result in improvement, there's no guarantee. So it could be good, it could be worse. And there are drugs that have made it all the way through the market, and we found out afterwards that they had some terrible side effects. So the results of trials always represent an improvement of the treatment. And that would be true. That's false, sorry. But the new interventions are slightly more likely. So researchers conducting an ethical clinical trial hope that their new treatment will prove to be superior to the standard treatments already available. Answer? Yeah, I don't think anybody spends hours doing this for no reason. Ha! So we always look to improve treatment. False. Researchers conducting a clinical trial hope their treatment is better, and that is true. And so what's the process? You get asked to be in a trial. We want to answer a question. If you get asked to be in trial, the question is, what's the question we're trying to answer? Are we trying to determine if something is a better treatment? Are we trying to determine if something gives you a better quality of life? Are we trying to determine if something lengthens life? So in some cancer therapies, or even with the pulmonary fibrosis drugs, we're talking about extension of life, but not reversal of process. So the quality of the trial depends on the question, building on the evidence, and a good design. So the researchers, the people who do this, we have to follow the plan. We have to follow the protocol. And that ensures your safety. If we don't, we could get shut down by the FDA, and that's not something you want to get to happen to you. So some of the trials are conducted on one group, but most trials will compare two groups. And I'll tell you about the different kinds of trials, so if you ever get approached, you sort of know what group you're in. You can't compare apples to oranges. So the two groups have to be very similar, pretty as similar as you can possibly get. Same conditions, close to the same age, same PFTs, same disease, which is it may have been an issue in some of the earlier IPF studies based on what we know now. So the clinical trial process, you're assigned to one group. Either you get the treatment or you don't get the treatment, and you're randomized to one or the other. And that's the randomized trial, and that's what a lot of you would be participating in if your doctors told you about the trials that are currently out there. So sometimes one group is the experimental group and one is the control group. So the control group is the one where you're doing what you would do if you weren't in the trial, but we're going to compare what the people get the treatment to you. So they're treated with the same care as the active group, though. So one of the things people don't always realize, one of the pluses is you actually get pretty close clinical care because you're going to be watched like a hawk, whatever group you're in. The researcher does not know what group you're in. We are blinded generally to what group you're in. So all we know is you get a pill, could be placebo, could be treatment. You're in one group or the other, and there's no way for me to tell unless the drug has some very interesting side effect that you get. But I've seen that happen in the placebo group where people got that horrible side effect, and when we find out later, they actually weren't on the drug. So the mind can do very interesting things if you believe you're in something. So for some diseases, and this was IPF until 2 years ago, we had no standard treatment. So basically, we could do placebo studies. But now that we have an actual treatment, and that slowed the clinical trial world down a lot in IPF when the two drugs were approved back in 2014, is that now they had to actually compare to one of those drugs. And it's very hard these days to get an IRB to approve placebo because you're saying, I've got an FDA-approved drug, so I can't do a trial unless I'm comparing it to something that we've said improves the disease or affects the disease in some way. So when testing the new treatment, clinical trials have to give priority to protecting your safety and well-being over everything. Is that true? I hope so. If not, please leave that trial right away. Don't even sign up for it. So the clinical trials we have to give priority to. And I tell my patients this. I said, look, when you sign up, if you're getting worse or something's going wrong, I will personally pull you out of that trial and watch you go down the tubes. That's just my personal opinion. And I always require that the trials I enter have what I call an escape clause, that we can do something if you're not doing well and you're in the trial. So when testing a new treatment, controlled clinical trials have to give priority. We said that. So the control group always receives the less effective treatment. Yeah, because sometimes we've tried things that did not work out so well, and the control group actually did better. So that is true. We do not know until the trial is over, which is better. Oh, there. All right. So there's a group called the DSMB. It's called a Data Monitoring Safety Board. They have to be in every single trial. I actually sit on one right now that is involved in stem cell research. And we get to look at the data before anybody else. The investigator doesn't know, the sponsor doesn't. And what you're looking for is to see if one therapy is better than the other or one is more harmful. So if one therapy, say your intervention therapy, is so much better, those patients are just way and above the others, you actually have the authority to say, stop the trial. We've shown that drug is so much better, it's unethical to continue the trial, we already know the drug works. Conversely, if that intervention people are doing much worse, you also have the authority to say, no way, this drug is making people sicker, stop the drug, stop the trial, and that's that. And that the sponsor has to listen to you. So The DSMB actually has the power to keep a trial stop, and if everything looks sort of equivocal, nothing's really standing out, you say, okay, keep going, people are safe, there's nothing dramatic, we keep moving forward. So the process is basically, after you've clearly understood the benefits, then you could consider entering. But it's really important that you receive essential information. I tell people, if you don't understand something, ask. There's no stupid question, there's stupid answers, but there's no stupid questions. So always ask the question. And informed consent is what that means. Basically, it means you need to have all the information to decide whether this is a yes or a no. And usually you meet one of the clinical trial researchers, and they have to explain to you the risks and the benefits. And you also get a sheet of paper that says it, and I call it in plain English, not medicalese, that clearly states what the trial is, what the benefits are, what the risks are, what they're going to be doing, and so on. So after that meeting, the researcher then gives you the detailed information about the clinical trial to help you decide. So if you decide to enroll, then you sign your informed consent. You always, always, always have the right to say no. And you should not feel guilty by saying no. If you think this is something that doesn't work for you, say no. It doesn't help you or the investigator to go into a trial because you feel guilty, because you won't stay in it. And it doesn't help anything. So if you really don't feel comfortable, and if your doctor is upset about it, then there's something wrong, because really it's a choice. If you don't want to do it, then don't. And I always say, it's always up to you. I will not take offense if you say no. We will just take a different path, and that's fine. There's nothing wrong with it. So it ensures that you do not enroll without having received that detailed information. That's required by the FDA, and a researcher could actually lose their license if this isn't done correctly. I'm going to move through that. So every so often, things change. So if there does, you may be given a new informed consent, not because something's wrong, but predominantly because we had some additional information to add, or they changed how they were doing something in the study. So it also, again, doesn't obligate you. You may leave this trial at any time. You could be a year into it and say, I don't want to do this anymore. You do not have to give any explanation. You can say, I'm done. I really just don't want to do it. And that's okay. Nothing wrong. So once you've signed it, it is possible to leave the trial. Always. Some people are scared that this is like a binding contract and you're stuck. Not true. You can always leave. So always ask any questions, and if you go home and have more questions, call them back and ask it. Be very, very comfortable before you sign or before you agree to the trial. And it's essential that you understand it. So always ask. If something doesn't seem clear, ask until it is. So what protection is for you? I mean, there's lots of interesting experiments that have happened, like in the Nuremberg trials and in the Tuskegee experiment, have led to the development of patient protections over the years. The basic ethical principles and legal codes, we're actually required to test on this every 2 years to make sure that we keep current on this. But they're governed through international guidelines and legislation. So you're checked for safety. We're checked for the ethics committee. The IRB goes, we have an institutional review board that reviews the trial, and in light of saying to the patient, well, this is not safe for the patient. And they will ask you all these questions. You have to justify why you want to do stuff. Well, why are you doing 18 blood draws? And why do you need to do 20 CT scans? Isn't that too much radiation? And so on. So these are really vetted pretty heavily before they ever get to you. So results from the trial should be made public. That's key, because you don't want to spend 2 years in a trial and never find out what happened. People would sometimes, in the past, if it was a negative trial, not want to tell anybody there was a negative trial, so it would get buried somewhere. It's like, wait a minute, I spent 2 years, doc, what happened with the trial? What's going on? So they actually need to make it all public, whether it's positive or negative. However, the identity of the participants is always, always, always confidential, unless that participant chooses to come out and say they're in the study. So it's standard practice to keep that information locked up somewhere, encoded, encrypted, believe me, all kinds of secrets. It doesn't get out. So where can I find clinical trials? For those of you who haven't participated and might be interested, there you go. Any of those websites, ask your doctor. If your doctor doesn't know, Mr. Internet, Mr. Google, but those websites are the ones. Clinicaltrials.gov is the one where most trials are listed, and I actually went on there. Right now, and you can actually look for trials that are actively enrolling trials that are not actively enrolling but are available, trials that are upcoming that are listed. Every trial in the United States has got to be on that list. That's required. So right now there are 75 active and currently enrolling trials in pulmonary fibrosis in the United States. So, just to put this all together, we have controlled clinical trials are testing new drugs, and they have well-defined aims and methods, okay? They're the most reliable, and they are the safest way to assess whether a treatment works better than, a new treatment is better than the standard. And we have to assess and authorize, we have to go through all the committees before we go through this. So, voluntary, you can quit any time. Your personal data and your rights are always protected. Patient is always first. So, as evidenced by this room, many people who could potentially benefit are unaware of them. Some groups are underrepresented, and the NIH actually requires, if you get money from them and do a trial, you have to guarantee that a certain percentage of your patients will come from, when you submit it, you have to say, okay, what percentage of patients do you think you're going to have that are minorities, or that are older people, or that are women? Because like the heart studies, many of the cardiac studies were done in men. Only to come find out heart disease in women is very different than heart disease in men. But initially, everything was generalized to the general population. So people are realizing that when we do these trials, the information that you see, you need to look at the group that was studied. It applies to that group. It may not apply to you if you're not that person in that group. So before being included in the new trial, it has to go testing in the lab, and it has to show promise. So it isn't sitting in the lab and concocting a test tube and saying, all right, I'm going to try this and see what happens. But we actually have to go through trials, and there are 4 phases. The phase 1 trial is usually, and this is preclinical, so this is clinical, I'm sorry. Before this, there are all the animal studies, the mouse studies, the rat studies, every other animal study you want to think of. Phase 1 is the small trial where they get patients who are normal and patients who have disease, a very small group. And all you're looking to determine is whether this drug is safe to give to people. So you're actually taking a little bit of a risk when you do one of these. But it's a small group. They don't tell you how well the drug works. They just tell you that it's not going to have you keel over and die the minute you take it, basically. It does help also determine how much of the drug you should get before it's toxic. Phase 2, the ones most of you would be more familiar with, 2 and 3. So basically, they provide safety and efficacy. These are the trials you might get into that will not have a placebo because they want to sort of see that there's an effect of the drug. They want to do a little more studying of the drug, so you might actually know that you're getting the drug, but you know the safety profile because the phase 1 is done. And I'm looking to see if it works. Is it better than the current standard? And it takes about 2 years, large number of patients. And sometimes it's randomized, sometimes it's just everybody on drug. And then the phase 3, that's the big ones. So these are the ones that involve hundreds of people and sometimes thousands. And they only go to phase 3 if the phase 2 trial shows some type of benefit. Okay? So these are usually national and worldwide studies. And this one you're looking at the side effects, and this is the trial that has to be completed and be positive before your drug can get approved by the FDA. So these are pretty involved trials, and on average, phase 3 trial will probably run anywhere from $35 to $50 million to do. Hence the very expensive cost of some of those drugs. Still think they're still a little too high, but that's my opinion. Phase 4, clinical trial, is what happens after the drug is approved. So the drug gets out, now you have everybody on it, and now we get to see side effects in real life. So remember, in the trial you've got, oh well, we can't have you if you have renal failure, we can't have you in the trial if you have, your liver functions are a little high, we can't have you in a trial if you're under the age of 40 or over the age of 80, can't have you in the trial if you have this PFT. Now, you have all those people getting the drug. So now the company's marketing to see what are the side effects in the real world when people are taking this on an everyday basis. And some of the Esbriet and OFEV trials coming out now are actually looking at this kind of information. And actually the study I'll show you here in a minute. So how can you get involved? This is a website that sort of tells you a little bit of what I just said in summary. It's actually a lot of nice little information about clinical research trials, why, where, how, and so on, apart from the actual trials. And that's the website itself. And it's some volunteer stories and research stories, and so it's a nice educational site in general. And this is the map I pulled off of clinicaltrials.gov that tells you where all the studies, pulmonary fibrosis studies are. And if you notice, they're concentrated in the United States with very few in the rest of the world. And then Europe has 11. But everybody else is much smaller numbers. And I don't believe that's because PF exists. I think it's just a different demand in healthcare system. All right, so here's your opportunity. I was at a workshop at ATS, and the workshop was for recruiting underrepresented minorities to do research. And one of the nurses there does asthma research in New York, and she came up with something that I thought was very interesting and I would like to do. I think we should do more of. She partnered with people from the community to write a research grant. And what she also did, she went out into her community and said, what would be important to you for us to fix? I can think of one off the top of my head. I will bet if we could find something to help with IPF cough, hands up. Yep. And I thought, well, why not ask you? You're the people in the body. We have not caregivers, Patty. Supporters, thank you. Supporters, that means Bill still has to wash the dishes. Supporters. What things, and I would love to hear back from you, what kinds of things you would like to see. I know everyone wants to see drugs, but think about quality of life issues. I think, Bill, we've had this discussion about oxygen, and there's actually a recent trial that came out about oxygen that was presented, recent paper, in interstitial lung disease. So there are lots of things that I think collaborating with actual clinical trialists now, with patients, we might come up with things that make your life better, improve quality of life. Maybe we don't fix the disease, but maybe we make life better. We make each day more fun to get up and go to. So I would love to hear about that. Now I'm going to go switch gears a little bit and talk quickly about a few of the trials. And the first area was sarcoid. And I don't know if anyone in this room has sarcoid, but sarcoidosis patients also get pulmonary fibrosis. And they also get pulmonary hypertension, and they have a higher mortality. And so basically, this were two trials that were presented as major trials where these patients are at a higher risk of death than the general population. And that's in part, this is a disease, for those of you who don't have it, can present and develop severe pulmonary fibrosis. And they get pulmonary hypertension, and it looks like the UIP pattern for some it doesn't. And they also can go to lung transplant, just like IPF and other forms of pulmonary fibrosis. So those were two studies, but I want to focus on the next few. So there are two ways I sort of looked at this. One was symptom-targeted treatment, and then the other one was actual drug treatment. So starting with the symptom-targeted treatment, some of the three bigger papers that came out. We're dealing with the safety of benzodiazepines, so those are things like Valium, Ativan for anxiety, and opioids. So as you all know, we have this wonderful opioid crisis, and everybody's talking about it, and people are afraid to give you anxiety medications because they're afraid you're not going to breathe well. And actually, so they decided to say, well, is that really true, or are we making assumptions? So that's the kind of idea you get with a clinical trial. People who are anxious and depressed, can we give you opioids for your cough without worrying about, too severe altered mental status or respiratory depression or addiction? And so this is a European study done in Sweden, and they actually keep these registry records for years. So they went back and looked at all this, and it turns out giving somebody a small amount of benzodiazepines and opioids to help with cough and or anxiety/depression did not actually make people worse, and in fact, it improved quality of life. So one of the things to think about. Then there's the nintedanib, OFEV plus sildenafil. So a lot of patients with pulmonary fibrosis have have pulmonary hypertension. And sildenafil, otherwise known as Viagra, is used to treat pulmonary hypertension. And the thought was, if you can put these two drugs together, do people do better? Because previous studies just using sildenafil alone did not show any benefit. And these were like 10 years ago. People tried to say, if we give you sildenafil for your pulmonary hypertension. Now we have nintedanib plus sildenafil, and actually the studies showed that there was benefit. Patients had a better quality of life, and they were breathing better with that combination if they had pulmonary hypertension with their pulmonary fibrosis. And the cough I'm going to show you here. So this was part of the guidelines. One of the ideas of looking at cough. And so cough can be either due to your interstitial lung disease or not. And I always, in one of my lectures, when I talk about pulmonary fibrosis to the house staff, I always ask them not to get tunnel vision about a patient's complaints. So if you get more short of breath, don't assume it's pulmonary fibrosis. Could be your heart, could be a blood clot, could be anything. Could be your thyroid. Always think outside of that box. So they tried to get people to sort of think that way and not assume that the cough was just ILD. Could we do something to make it better? And so after ruling out infection and everything else, you can either treat it, we look for whether your esophagus is working correctly. So patients who have scleroderma may have acid reflux that's silent, and sometimes treating that gets rid of it. Asthma can get rid of it. There's something called irritable larynx and chronic cough. I have a wonderful ENT colleague who's very good at this. All she does is vocal cords. She's had some very good results in some of my patients improving their cough. In terms of you cough so much, it becomes habit, and there are ways to train it so it's better and it's better controlled. So there's a whole guideline here, but just to say cough, we have this wonderful guideline. There are no real trials looking at this moment in time. There have been in the past. Nothing's been successful as of yet. And then I'm going to talk a little bit about treatment. So this involves some of the new drugs that were presented at the meeting this year. So this is human penetraxin versus placebo. And so what's the effect of this drug on your PFTs in patients with IPF? So while everybody's looking at me, what in the world is that? There's my question there. It's just a protein, and what it is shown in mice, it's shown to reduce fibrosis in the mice models. So if it reduces fibrosis in mice, maybe it'll reduce it in humans. I will say there's a lot of going back and forth in the research community. Look, we find this works in mice. Mice are not humans. So that's where a lot of the connect has sometimes fallen off. And in these mice, the way they give them fibrosis, they give them bleomycin, which is a drug that used to be used for chemotherapy decades ago, but we know for a fact causes pulmonary fibrosis, so they induce it. And some people have made the argument that that's not the same kind of fibrosis as pulmonary fibrosis. So some of them, then they make the argument is that may be why when we try these trials in the human setting, they don't work as well. Nevertheless, this one went forward, and they randomized the patients in a 2-to-1. So 2-to-1 means basically for every 3 patients, 2 of them would get the drug and 1 would be on placebo. And the endpoint, they were looking at the change in your spirometry, your PFTs. And I thought this was an interesting line. I put it in there because it said they found that men were, so basically you could be whatever therapy you're on, you could stay on it. So if you're already on IPF therapy, you could stay on it. You would just be randomized either to receive no additional therapy or to receive this drug. And I found that most of the men that they recruited were more likely to be receiving therapy than women who were recruited to the trial. I would like to know why. I'm not so sure. I don't know if anyone picked up on that, but it was. And then 15 patients, 12% of the patients had not received any IPF, so treatment in the past. So I don't know if that was they didn't want it or they were never offered it. But It seemed to be well tolerated. The adverse events were cough. They had some elevated liver testing, and a couple of patients developed pneumonia, but it did show a modest improvement in the forced vital capacity. So, having said that, what that means is, when I told you about the phase 2 trial, this is something then you would advocate that maybe now we can go do the phase 3 trial. Seems to be well tolerated, seemed to be positive. Now let's see if it pans out when we give it to a much bigger group of people. And then this one, some of you may know of Ganesh Raghu, who's one of the ILD gurus. He trained me. And he has said for decades, even when I was training, that patients with IPF have acid reflux, and the acid reflux affects their lungs. And he's finally gotten a lot of people to start believing in it. Part of the reason is the guidelines has everybody with pulmonary fibrosis should be on some type of acid reflux treatment, even if they don't have symptoms. Partly came from some of that research. So the theory of this group was, well, what if we surgically repaired your GERD? So did what's called a Nissen fundoplication. So basically, take your esophagus and take a piece of your stomach up and wrap it around like a purse string almost, so that the acid can't get back up. At least it can, but not to the extent it was before. So these were patients with severe acid reflux, with pH probes and everything. And patients, whatever drug they were on, they remained on. There was no change, and they split it 50-50. It didn't really show a change in the FVC, so they were equal in that sense. But it was tolerated. But they did note that those who had the surgery seemed to have less exacerbations and less hospitalizations long haul. So hit or miss, it's a thought. If somebody has severe reflux, something to think about. And then this is the third trial. Some of you know about this, is the Galapagos trial, basically. It's an autotaxin inhibitor. And you go like, what in the world is it? Basically, it's an enzyme. And it's been found to help with cancer motility. And basically, this drug helps with reducing fibrosis. So these are patients with confirmed IPF. This is a 1 to 3, so for every 4 patients, 3 patients got the drug and 1 was on placebo. These patients were found to have increased risk of infection, but they seem to have a slower rate of decline in FVC, so similar to the Esbriet and pirfenidone. So now there's an ongoing phase 3 trial going right now, results pending. And then, to Bill's favorite topic, oxygen therapy. So we give patients oxygen, right? Your oxygen levels go low, oxygen should work for you. That's the theory. But there is absolutely no data, no studies that show that oxygen helps in ILD. I like this trial because it gives me ammunition for my patients who told me they don't want to wear their oxygen. I have a few. What we have been doing is saying, well, it helps in COPD, because for COPD patients, oxygen is the only thing known to prolong their lives. We can give medications, we can do whatever we do. There's only one study that showed life is prolonged with an intervention, and that's with oxygen. So the theory was, let's give everybody who needs oxygen. So they did, and Randa said, well, let's prove it works for ILD patients. Maybe they're not the same. Maybe they are. Randomized controlled trial, patients who had exertional hypoxemia. So these 84 patients who either had supplemental or no oxygen. Some of you may be thinking, well, if you need oxygen, how do you keep patients off of it for extended time period? What they did was a 2-week, what's called crossover study. So basically, the patients needed for 2 weeks were off oxygen and 2 weeks on it. These were only exertional oxygen, so not people who needed it 24 hours a day. And then they went and looked at quality of life issues for people who were, for both groups. And everybody who was on the oxygen actually said they had a high, they scored higher on the quality of life testing when wearing the oxygen. So this is our first study actually to ever assess the effects of oxygen on quality of life. Message for me to patients who don't like wearing oxygen, please wear your oxygen. I actually have studies now that back up my beating you over the head to wear your oxygen when you walk. Hey, don't believe me, I do have people I have to convince to wear their oxygen. Happens a lot, you'd be surprised. And then this one. So we have 2 drugs in the market. Some of you may have asked this question. If one is good, why not 2? right? You take nintedanib, why not take pirfenidone? If one isn't working, let's add them both together and see what happens. So this is exactly what they did. All the patients had to be on OFEV at full dose, 150 milligrams twice a day. And then they added in the pirfenidone. And there were two groups. Either you were on nintedanib plus the pirfenidone, or you were just on nintedanib by itself. And what they were really trying to figure out, so two questions. One, what's the side effects going to be like? Because you know the side effects for OFEV, the worst one is diarrhea. And for pirfenidone is a lot of the GI, acid reflux, dyspepsia and all that kind of stuff, nausea and so on. So you can imagine throwing those two sets of side effects together. 67 patients had the GI side effects in the combined group, 57% in the only nintedanib group. But it did seem to suggest, not final, a slower rate of decline with combined therapy. And I said seemed because it's a small study. And one of the things we have to do with clinical trials, we have to power them. We have to make sure we have enough people to prove what we set out to prove. They were looking more at safety. So they would have to do a much bigger study, and I think there's a group actually doing another one now that's sort of looking at this combined. Because right now, there are no guidelines, and people, both of these drugs affect the liver. So you would worry about really hitting your liver with a double whammy if you had really bad side effects. So right now, it's still in study, but at least preliminary data suggests, other than side effects may not be, the GI side effects may not be the worst thing in the world. It may benefit. Now, I don't know if you pay double if you do that. Now we need a combined drug. Put them together in one pill, I suppose. So this was sort of how they did the trial. And they had 6 patients stopped it, but when they first started nintedanib, they didn't even make it that far. 105 got split, almost 50-50. And then 7 of these couldn't continue it both. We had 12 that stopped the pirfenidone only. None stopped the nintedanib only. But overall, the patients seemed to tolerate the drug well. So, last segue. For over 20 years, we've been fascinated with the idea of stem cell research. I remember when I first got out of my fellowship, I was on faculty at UT Southwestern. I had a patient who came to me with IPF. And he asked me about stem cell research. So you can imagine, that was a lot of years ago. Anyway, he actually knew about stem cell research going on in Thailand back then. We weren't doing as much of it in the United States. There was still embryonic and mesenchymal research starting, but it was in its infancy. But even then, people were looking to stem cell research for pulmonary fibrosis. So this is not a new thing. I don't have a big answer, a big trial. What I really wanted to do is, people throw this term around a lot, and I sometimes get the feeling that we don't really have a good handle on what we mean when we say stem cell research. It is definitely not all those centers that you pass as you drive down the road, come in here, or even phone calls that you might get, or emails for the stem cell research centers that look very professional. Those are not regulated by the government. Nobody knows what they do in there. And if anybody approaches you, save your money and keep walking. There are a few disorders in which stem cells have already shown benefit. We are working on pulmonary fibrosis. There's a lot of argument and discussion, and we can sort of see, I'll sort of touch on where the challenges are. So when you think about stem cells, they are different from any other cell in your body. And the reason why they're just so interesting is that they can divide and renew themselves forever. Pretty long time anyway. They're not specialized. They're not lung cells, they're not kidney cells, they're just generic, basically. But they can develop into different cells. So they can become your skin cells, or thyroid cells, or pancreatic cells, or cardiac cells. They can become any cell in the body. So when you think about it, it's pretty neat. The 3 kinds that we think about are the embryonic stem cells. These can renew themselves infinitely. And they usually come from the blastocyst of an embryo. And these are embryonic stem cell research in the United States is illegal. So it only happens in other countries. But we did actually have a COPD patient that was in a different country that did this, that improved dramatically, which is sort of very interesting to me. Then we have induced pluripotent stem cells. Okay, so this is reprogrammed cells. And then we have the adult stem cells. This is what we're talking about. This is what you're going to see all the research in, at least for pulmonary fibrosis. We're looking at MSCs. I'll tell you about them in a minute. We get those from our blood, bone marrow, tissues, and these can become all kinds of different cell types, and they can renew themselves over and over again, but they cannot renew themselves indefinitely, so not like the embryonic stem cells. So the mesenchymal stem cells, these are the ones that you're looking at and you'll hear about in all the research trials. They're like bone marrow cells, okay? And they are of interest because they can home to different parts of the body. So what they do is, if there's a part in your body that's inflammation, those cells are going to hone in right for it. That's the head traffic. That's where they go. So theoretically, if you have inflammation and activity in your lungs, guess where those cells are headed? They're going to head to those lungs. But if there's inflammation elsewhere, they're going to head there too. So potential therapies that people are looking at or have looked at, so something called graft versus host disease. This is something that happens after a bone marrow transplant very often. Crohn's disease, genetics disorders, transplants patients, cardiac repair, trachea repair, and even now we're looking at for lung disease. And in fact, about 10 years ago, there was and you may or may not know this, there was a very large stem cell trial for COPD. National trial for stem cells in COPD. Unfortunately, it was not a positive study, and for a little while after that, I think researchers sort of went back into their labs because nobody could figure out why it didn't work, and we'll talk about why those challenges. Now we probably know a little bit better than we did then. So all stem cells basically, doesn't matter where they come from, they can divide, they're not specialized, they give you special cells. We care about the mesenchymals because those are what you're going to see all your research in when people are talking about that. So here are the challenges. I told you that these cells tend to go to the inflammation in the body, but that's anywhere. It doesn't have to be just the lung. Now, the stem cells from patients with pulmonary fibrosis are an issue because most of those cells come from you. They'll take it from your blood and they'll process it, so they get the mesenchymal cells out from you. The problem what they find with some of the pulmonary fibrosis patients, at least in the past, is that the DNA may already be altered. So if there's a genetic piece, the DNA is altered, you're not going to get brand new normal DNA from abnormal DNA, so that's a problem. And there's some workarounds that are currently being researched to sort of try and adjust to that. The other thing we don't know is about the interaction. So when we've done some of these trials, most of them all phase 1 trials, patients have tolerated the drug pretty well. The problem is we don't know how much you need. We don't know how many stem cells you need. Do you need 10,000? Do you need 10 million? How much does it take to actually make a change? That's part of the research right now too. Furthermore, is it better to give it IV, sub-Q? If you go to some of these, I call them roadside stops, they actually give them subcutaneously, so I'm told by some of my patients who've done it. And then, once we actually do it, what should we be looking for? I mean, I want your lung function to get better, I want the fibrosis to get better, but what else should I be looking for? Are you going to be at risk to get more infections? Are you going to be at risk to get something else down the road? We don't have really very good standards that are currently in existence that you can sort of say, okay, check the boxes. So in the stem cell world, it really is sort of still the Wild West. Most of the stuff is in the lab with animals. There are, now we have trials for COPD, we've had trials for bronchiectasis in stem cell, trials for pulmonary fibrosis in stem cells, and what's the fourth one? Asthma. That's the fourth one. The other problem with it is, remember, your lungs are open to the entire environment, so you breathe everything in and out. So you're also constantly having to respond to changes, pollution, and so on in the environment. So the cells are trying to do what they need to do, but they're constantly receiving an input of all kinds of stuff in the air. So it's an ongoing battle. It's not, it's made significant progress, but long way from prime time, still. Certain disorders are better than others. I think the other problem with IPF Challenge is that we don't have a start point, so nobody can tell me or you exactly how you got your pulmonary fibrosis. If it's autoimmune, it's a little easier, but even then, what exactly happens in the lung that you get fibrosis from it? I mean, those are questions that are still being answered or looked at, so we have a ways to go here. I just wanted people to have an idea of when we say stem cell research, this is what we're talking about. We're still a ways out, but there's still a lot of work currently being done with the mesenchymal cells. And they also, remember, I told you they don't replicate indefinitely. So what happens when they stop replicating? The other stem cell types will replicate indefinitely. That's plus or minus. What if it turns into a cancer cell? That wouldn't be a good thing either. So it's still challenging, but if you want to go do some research, there's a ton of great research out there. It's still in its infancy, despite that. And then there's all the ethical implications of doing stem cells. So I will leave you with either you're on one end or the other, but if you have questions, I'm willing to take any and all questions, even if it's not related to what I just said.
Question you're talking about with stem cell, basically dealing with the cellular, but then also you're talking about DNA with the new CRISPR. Is that being applied to this? Or?
Not yet to this group, but the CRISPR is another, yeah, it's actually, so the CRISPR that's pretty cool. If you guys don't know, it's sort of a very, almost, it's the concept of precision medicine. You can pinpoint a gene or a specific disorder and make changes directly to the DNA. And then as a result of making that change, everything downstream changes. We still don't have a good handle on the pathogenesis of pulmonary fibrosis. That's part of our problem with CRISPR. Things like diabetes and heart disease have very specific pinpoints, so it's much easier for them to hit it. For us, I mean, everybody in this room, I am going to put money, has a different diagnosis. You know, we'll have IPF diagnosis, I'll have autoimmune diagnosis, I'll have hypersensitivity pneumonitis, I'll have sarcoid, and every one of them starts off different. So that's been a little bit of a problem, but it's super exciting research. If we can get to a point where you can get to that exact gene. And now the genes we are finding for IPF, maybe. Some of the research shows that certain short telomere and the MUC5, those are the two, that are clearly associated with PF. I don't know anybody looking at CRISPR specifically for those genes, but could be interesting coming down the road. Getting funding is the other issue. Somebody has to pay for this. All right. Bill.
A question, and probably like many of us here, we are told by our doctors and others to exercise, to eat right, think right, move right. Sometimes if you're carting around a couple of tanks, it's hard to move right, because getting from the chair to the bathroom is a marathon. So when you say exercise, and I look at kind of the empirical results of the people I know and talk to, and almost without exception, those that exercise have a better pathway in living with the disease. But I don't see any studies on that or any trials on exercise. Why?
Because we're going to do it. We'll do the exercise trial. There we go. We have a great rehab center right downstairs on the second floor. We can do it. Well, and to... Absolutely, but that was what I was getting at the question. So what's important? Now, I will tell you, we are getting ready to do a trial, sort of along those lines, with patients who are on nintedanib and in pulmonary rehab, and the goal is to see if doing rehab improves their function. They have to be ready on nintedanib, but I think it shouldn't have to be just on nintedanib. That could be... I mean, to be honest, you're exercising just getting to the bathroom with 2 e-tanks. Frankly, that's a workout in and of itself. But no, that's what I was getting at. What's important that we should be looking at that people aren't doing? Exercise. Thank you.
I have a question. When does a study go into a clinical trial? Because my husband presented lung issues far before he ever presented his rheumatoid arthritis, but his diagnosis is that the RA caused the the pulmonary fibrosis. But he was in a study at University of Colorado where they thought that there was a rogue bacteria or protein that got in the lungs and it would cook there for years and years and ultimately create all this inflammation in your body, which might show up as rheumatoid arthritis or scleroderma or lupus or whatever. And we never found out the results. We'd like to know if they found that. But then they had some studies within that study about does dental bacteria go rogue and get into your lungs like it can in your heart. So they did come up with a genetic defect, a MUC5, if you produce a whole lot of mucus. And we assume that pertains to Scott, but they never tell us. We'd love to know all these things that they were looking at him for.
So I can tell you, if they never told you and you didn't see it published, the odds are it was a negative study. However, I would say call up the center and say, I was in X trial and I'd like to know the results, because they're obligated to give you the results of the trial. So I would call them and ask them, so what were the results of that trial? And if it was a randomized trial or a blinded trial, they can unblind at that time because the trial's now over. Some people don't care, some do, but the trial center should at that point be able to unblind and say you were on drug or you weren't on drug. So I would call them and find out. The thing with pulmonary fibrosis is you're alluding to something sort of, that's why I say, when you go back to the early studies 5-10 years ago, all the people in there who were IPF, I'm going to bet there's probably a percentage of them that were autoimmune. Because this idea of autoimmune lung disease or connective tissue associated interstitial lung disease wasn't formalized until maybe 5 years ago. IPAF maybe 1 or 2 years ago. But we used to argue with the rheumatologist. I remember this distinctly. Look, rheumatoid factor is elevated. I know they don't have joint pains, but can this not be rheumatoid? And they don't want to say no. And then finally they're getting to the point where, okay, you know what? You can have pulmonary fibrosis and rheumatoid disease without having joint symptoms initially. It's taken a while. I mean, I have to say this about my profession. You don't like change. Sorry, I just don't like change. Yes, ma'am.
I can speak to that because I was actually diagnosed with NSIP first, simply because had no symptoms, nothing. Had an abdominal CT scan done, and the abdominal looked fine, but my gastroenterologist said, your lungs don't look good. And I'm like, what? And so go to Dr. Silhan at UT Southwestern. She diagnosed me with an SIP, sent me to a rheumatologist, who then diagnosed me with scleroderma. Although I don't have any symptoms for scleroderma, I'm not having any symptoms of, but that's where my NSIP and scleroderma came about.
But you have the abdominal pain.
No, so I got Campylobacter over the summer, and because of the Campylobacter, I got the CT scan done.
Because in scleroderma there is something called bacterial overgrowth, and people will get intermittent belly pain and so on from bacterial overgrowth and bloating and so on.
Right. I haven't had that. I just had the Campylobacter.
See, that's so, I guess, in the corner over here would probably back me up. It's really important if you have interstitial lung disease to be seen at an ILD center. I mean, you guys are lucky. We have 2 in Dallas. We have 1 here and 1 at UT. That's really imperative, because you will find, I can't tell you how many times I have people come to me with IPF, and then I start taking a history and somebody says, oh, I have rheumatoid arthritis, and I stop right there. So, okay, time out. You can't have IPF and rheumatoid arthritis. They don't go together. It's A or B. It's not A and B. So that changes the whole dynamic right then and there. Or maybe I'll find something because I do the studies. So it's really important to make sure that you're seen by somebody who is experienced in the interstitial lung disease world overall. That's key. See, they're nodding over there.
My PCP referred me to a doctor, within their network that had nothing to do. He specialized in like sleep apnea and things like that. And I stopped and I said, no, I want to go to Dr. Silhan. She specializes in NSIP. And so she referred me then over there. So I had to do with my care. I stepped in and said, no, I'm not going to that doctor. So.
No,
You can do that.
Patients have to, you have to advocate for yourself. You have to do that. If it doesn't work out, then you have to not just accept it. You have to say, okay, I need to find somebody.
It drives me crazy. What she says is so right. We have to be advocates for ourselves. At some point in time, we forget before we were patients, we were people, and we still are. And once you think of yourself as a patient, you become a patient, and you're standing up for your rights, and God bless you. We should all be doing that exact same thing. But we come from a generation where doctors were on pedestals, and policemen were always good guys, and it's hard for us to confront a doctor and say, oh.
Well, then don't confront them. Go find somebody else to go.
We're people first and foremost, and that's why I love what you're saying.
Yeah. People first.
Well, it's
People
important,
first and foremost.
it's important to find a good doctor in good relationship and then be compliant with that doctor.
Right,
With that doctor's
absolutely.
orders.
Yeah.
That's where you get success.
So, yeah, you make a good point. You have to be able, and I will say this even if you're an ILD doctor, you have to be able to communicate with your doctor. I don't care if it's PCP, pulmonary, whatever. If you can't, then you need to find someone you can, because if you can't talk to that person, you can't tell them what's wrong. I also have this rule: if a patient is in my office and there's a spouse in the office, I guarantee you there's something the patient isn't telling me that the spouse is going to make sure I know before they leave that office that day. So I will let the patient go and I turn to the spouse. Okay, so now what do you have to tell me? Because I know you're here for a reason. And always, always, always there's something that I need to know, but patient isn't going to tell me, but spouse is going to make sure I know about it. Or significant other, which I think is really fun. It's my fun days.
As to her comment, I'm doing the same thing with the endodontist right now. I've got a root canal that needs to have redone. And we checked with your office and you said have to have antibiotics. And they're not saying no, they're just dragging their feet. So I just keep, after I'm asking.
Who's dragging your feet? The dentist?
Actually, I think it's the staff at the dentist's office, not the dentist itself. Well, we have patients that need to have antibiotics. And I said,
Yeah. You're one of them.
Yeah, but it's like I have a Tuesday appointment, Tuesday morning, and I said I have to have these to start before the appointment. And they're dragging. So I'm going to check with them Monday morning if
See me
it's not
before,
ready.
we'll fix it before you leave. See me after.
But if we're not ready, then I'm canceling the appointment
Yeah.
and
Go to
putting
someone
that.
else.
So it's not just doctors
Mm-hmm.
that are
Yeah.
doing this.
Office.
And dentists are kind of, up there anyway.
Yeah, we
as
get
far as
those
that.
requests all the time.
Yeah.
It's like, guys, it's not rocket science. Yes, ma'am.
Could you speak a little bit more about that relationship or maybe non-relationship between RA patients or RA and the idiopathic pulmonary fibrosis? And my question, I guess, is does having RA maybe perhaps send you down another track that delays understanding if it is IPF?
So, actually, I think what you're getting at, and my guess is you probably got told that you have IPF,
Yes, they said maybe it is. Yes.
but you have rheumatoid arthritis.
Yes. Exactly.
Not. No. You either have rheumatoid arthritis and rheumatoid lung, or you have IPF, because IPF by definition is idiopathic. We don't know. We know for a fact that RA can cause pulmonary fibrosis. So I'm not going to give you two diagnoses when I already know you have one. So the IPF goes off the table, and you just have rheumatoid lung. So the way you want to do that is you're going to treat that by controlling the rheumatoid arthritis. Does that mean you don't get one of these antifibrotic agents? Not necessarily, because one of the other studies I didn't present was the scleroderma patients. nintedanib, or the OFAB fibrotic drug, was just approved for patients who have pulmonary fibrosis from scleroderma. There is an ongoing trial for using pirfenidone in rheumatoid arthritis, still waiting for those results. So it doesn't mean you wouldn't get those drugs, but it puts you in a different category. So it doesn't put IPF, IPF is not, it's rheumatoid, it's called rheumatoid lung or rheumatoid fibrosis. So it's a different thing altogether.
Any other questions?
Excuse me, I have a question. With pulmonary fibrosis, I mean, what's the number? I was told like IPF is very rare, but it sounds like there's a lot of pulmonary fibrosis out there, but not IPF, where you don't know, or is that all one category?
So, see, I told you I shouldn't have the other lecture.
I have good slides for this one. So what we're talking about is, okay, here's how I'm going to tell you how I think about it. When you come to me and there's pulmonary fibrosis, I put 4 blocks up. Block number 1, I know what causes it. Well, actually, no, let me start here. 2 blocks. We know what causes it, we don't know what causes it. And though we know that causes it block are medications. Most famous are things like amiodarone, which is a heart drug, macrodan, which people take for chronic urinary tract infections all the time. Then there's some other long list of methotrexate, a bunch of medications. So then there's the second group I look at. Do you have a cause like an autoimmune disease? Rheumatoid arthritis, scleroderma, lupus, any of those other things. Or polymyositis, a whole list of them. Then there's a third box. Third box, what we call granulomatous disorders. So those are the sarcoids and the hypersensitive pneumonitis. Those are the people who have pulmonary fibrosis because of something they were exposed to that created an allergic type reaction in their lung. So if I said, case in point, I had a patient sent to me years ago who had really bad pulmonary fibrosis, and he was told he had IPF, and they sent him to me, he's IPF, see this patient. So I saw the patient, go through the story. Halfway through the story, his wife looks over at me and she says, I wish you would tell him to get those blank birds out of the barn. What birds? Pigeons. How many do you have? 150. Oh, that's a lot of pigeons. What are you doing with 150 pigeons? So homing pigeons was his hobby. We know that birds and bird dander, people who keep parrots, can cause a hypersensitivity reaction, and over time, you develop fibrosis. If I put up a CT that's more end stage with a IPF patient, they look almost identical. There's some subtle changes that I could tell, and I know this because I know what I'm looking for, but somebody looking on the surface would say, oh, those are exactly the same. They're not exactly. But that patient didn't have IPF. He had hypersensitivity pneumonitis, different disease. And he'd have to get rid of the birds, and he'd have to do certain things, because if he kept the birds, trouble was going to continue. And then there's the fourth group, and that's what we call the idiopathic groups. There's about 6 or 7 pneumonias. NSIP is in that group, even though it's technically can be associated with autoimmune, but if it's not, then it falls in that group. There's something called RBILD, which is associated with smokers. There's a bunch of alphabet soup things in there. IPF is the most common of those. So it is the most common idiopathic interstitial pneumonias. There's 5 or 6 of those that fall in the idiopathic. IPF is the most common of those. So that's kind of my 4 boxes that I put. If you fall into any one of the first 3, you don't get to hit the idiopathic box. It goes out the window. So the way I go through is I have to make sure the first 3 boxes are off the list. Then we go to idiopathic. Now I can confuse you a little bit more. You can be in that idiopathic box, like Scott Bear, and 5 or 6 years into that box, suddenly get joint pains and swelling and all kinds of things, and whoa, now your blood work and everything is classic for rheumatoid arthritis. And we'll backtrack it and say, well, that was probably your rheumatoid arthritis showing up in your lung before it showed up anywhere else. And that's why this gets sort of confusing, and you need to be with somebody who actually has done this for a while and actually knows what they're doing. So I hope that answers your question. It's a bit of a long answer, but it's boxes. You have to fit in the box. So IPF is common in the idiopathic group. It's the most common idiopathic, and the most, has the worst prognosis of any of them in the box. Mhm.
It has what kind of?
The worst prognosis of any of the idiopathic pneumonias.
The two drugs that are available, are they only for IPF or are they for other fibrosis?
So, there's the legal answer and the not legal answer. So let's start with the legal answer. The legal answer is they are approved officially only for IPF, with the exception of OFEB, which last month was approved for scleroderma as well. Not approved for anything else. Does that mean it's not being used for everything else? No. It's being prescribed off-label for lots of things. There are ongoing studies, though, to see if it works for the other fibrosis. So there are 2 or 3 ongoing trials that I would anticipate in the next year or 2 we're going to find the results out, or less, about how well it works for other types of fibrosis, other types. So officially not, but it's still used off-label a lot.
How do you tell with the patient that it's time to get on a medication? Do they have to, their tests have to fall to a certain threshold, or how do you make that decision?
And you're asking hard questions. I say hard because the reality of it is, and I sort of said this about the clinical trials, you have this set group that they said could be in the trial. So anybody who falls in that group is fair game to be in the trial. You had to have a certain forced vital capacity in a breathing test, a certain diffusion capacity on the breathing test. You had to not have any other certain diseases to be in the trial. But in real life, phase 4 clinical trials, my patient has pulmonary fibrosis. I don't want to have to go through all these hoops and say, if you don't check box 1, 2, 3, you can't have the drug. So in reality, and there's argument, and the reason I say it's a hard question because if you put a bunch of ILD docs in a room, there's a whole range of discussion about, well, if the patient is fine and they're not on oxygen and they're doing great, why would you want to put him on the drug? Why not just wait? And then there's the other camp that says, well, they're going to progress. We already know they're going to progress, so why not put them on something now? I think more and more people are moving to the, why don't we put you on something now? Unless you've been a patient who's had fibrosis for 10 years and hasn't changed. It's like, well, you haven't changed in 10 years. What are the odds you're going to change now? That's an entirely different patient. But for most patients, the general consensus in the in the ILD world is start early is better than late. So it's all who you talk to, but for most people have now moved into the start early, so you don't have to be on oxygen if you have fibrosis. That is key, though. I have seen people start on who don't have any fibrosis and turn out not to have IPF after we've done a few tests that they need something else and not a fibrotic drug. Yes, ma'am.
I was told I was too old to be in a study. What are the age limits?
That varies from trial to trial. Most trials cut off at 79 to 80. Most, and that's up to the sponsor. Some trials have no upper age limit. But they're worried that as you're older, they're worried that either you may not survive to the end of the trial, or they're worried that you have other disorders that would complicate things down the, whether you have bad heart disease. And it's an assumption, to be honest, but that's in general how they do it.
I have one more question. In your experience of treating people with IPF, have you ever treated a patient that had that in myelofibrosis, which is fibrosis in the bone?
Short answer is no. That would be a very interesting combo. The pirfenidone in its infancy days, they did look at that, actually. One of the things they looked at was kidney and bone marrow. I don't think it went far with the bone marrow, and I don't think that's because it didn't work. It just it got sidetracked into the pulmonary world and it sort of stayed there because I looked at it for scleroderma, fibrosis as well. So short answer is no, and I'm not sure if we even look in a lot of people.
I have both. And I've been in a support group for MPNs for the myelofibrosis since 2008 probably. And I went back and searched the archives, and there were patients taken this.
As good. Yeah, it was in its infancy days, it was actually studied for myelofibrosis.
So I didn't know if they were taking it for the myelofibrosis or if they also had the IPF. So just
It's approved for IPF, so I'm not sure that's, they're probably taking it for.
it's not approved for
No.
MPNs. I go to too many conferences to know that.
Unless somebody,
It was years ago. It was before Esprit was approved. When they were doing the clinical trials, they tested it, like you said, on the.
that was when it was a drug looking for a home.
Okay.
That's what I call it.
Looking for a pocket.
The out of pocket. May I? Okay.
Any other questions?
Thanks for having me.